Now, the topic from which we are going to cover MCQ is from what? From anatomy and embryology of oral cavity and pharynx, right? Okay. Now, the first question is not included in oral cavity cancer. Okay, to do this question, we need to know what are the structures present in oral cavity. So here, the base of tongue and soft palate, these are not the structure of oral cavity, these are the structure of oropharynx. That's why these two, A and C, are the answer. The capsule of tonsil is formed by, it is formed by pharyngobasilar fascia, right? Pharyngobasilar fascia. So if you see in tonsil, right, just lateral to tonsil, there is what? There is what? Peritonsillar space. Now this peritonsillar space consists of paratonsillar what? Vein, right? Now outer of this there is what? There is pharyngobasilar fascia. Now outside of this pharyngobasilar fascia there is superior constrictor muscle. Outside of this superior constrictor muscle, what we have? We have what? We have what? Buccopharyngeal fascia, right? Buccopharyngeal fascia. The pharyngobasilar fascia just outside of capsule, that is forming capsule, and outside of what? Our what? Superior constrictor muscle, there is buccopharyngeal fascia, right? Similarly, we have other structures also, like we have got what? We have got muscles, right? The medial pterygoid muscle, right? In between what we have got? We have got what? We have got mandible, right? Mandible, right? Similarly, there is what? There is glossopharyngeal nerve, right? There is submandibular gland. Submandibular gland is there, right? There are tonsillar arteries also. So these are the structure. Okay, now here capsule of tonsil is formed by pharyngobasilar fascia, which is not part of hypopharynx. Okay, now talking about the part of hypopharynx. Now what are the part of hypopharynx? These are, right, these are our posterior cricoid region, right, posterior pharyngeal wall, and what? Piriform fossa, right? Piriform fossa. The aryepiglottic fold are not the what? Not the part of hypopharynx, right? Okay, aryepiglottic fold are upper border of what? Quadrangular membrane, which is intrinsic membrane of larynx, right? These are the part of larynx, right? Okay, three piece, like posterior pharyngeal wall, posterior cricoid region, right, and piriform fossa, right? This wall constitute hypopharynx or laryngopharynx, right? Okay, Killian's dehiscence is seen in. Now where is Killian's dehiscence seen? Okay, talking about Killian's dehiscence, it is seen where? It is seen in what? Hypopharynx, right? Now talking about Killian's dehiscence, right? Killian's dehiscence, it is what? It is what? It is the gateway of tear, right? It is why it is the gateway of tear, right? Because here what we have? We have thyropharyngiasis, right? We have cricopharyngiasis, right? Now the inferior constrictor muscles has two part, thyropharyngiasis and cricopharyngiasis, right? The potential gap in between these thyropharyngiasis and cricopharyngiasis, that is what? That is at the level of vocal cord, right? Now that is at the level of vocal cord. This weak part, right, right, weak part is what? Is through which our what? The what? Our Jenkel's diverticulum comes out, right, from which there is the herniation of pharyngeal mucosa, right? Pharyngeal mucosa in case of pharyngeal pouch, right? And that is what? That is our Jenkel's diverticulum, right? Okay, that is the importance of Killian's dehiscence. Okay, now the eustachian tube open into nasopharynx approximately 1 cm behind. Eustachian tube open into nasopharynx 1 cm behind, right? 1 cm behind, that is what? Posterior end of what? Posterior end of inferior turbinate, right? Eustachian tube open in lateral wall of nasopharynx, right? Nasopharynx about 1.25 cm behind posterior wall of inferior turbinate. Which of the following structure is seen in oropharynx? Okay, talking about the structure seen in oropharynx, right? We have already said piriform fossa, it is not seen there, right? Palatine tonsil, right? Okay, now talking about the palatine tonsil, it is what? It is the structure seen in oropharynx, right? Palatine tonsil lies in lateral wall of oropharynx, right? And talking about this pharyngotympanic tube or eustachian tube, right, and along with fossa frozen molar is present in lateral wall of nasopharynx, right? These are eustachian tube, fossa frozen molar, these are seen with in lateral wall of nasopharynx. If you remember the posterior rhinoscopy, that in that we see eustachian tube and fossa frozen molar, right? So the structure seen in oropharynx, it is our what? Palatine tonsil. Which of the following is not included in hypopharynx? 3P, P, and P, right? Anteropharyngeal wall is not included. right? Similarly, the next question is lower limit of hypopharynx is, okay, that is lower border of what? Obviously what? Our what? Cricoid cartilage, right? Lower border of cricoid cartilage. Okay, now talking about the different site of hypopharynx, right? Talking about the different site of hypopharynx, the hypopharynx are divided into what? Into three types, right? Into three types. Now what are the three types of hypopharynx? The up one, right? Epipharynx, or that is also known as what? The epipharynx is also called our nasopharynx, right? Okay, that is also called what? That is also called nasopharynx, right? Nasopharynx or epipharynx, right? Epipharynx or the nasopharynx, right? It is the uppermost structure that is what? That is lying between what? Lying between skull bone to what? C6, right? Skull base, right? From skull base to what? Hard palate, right? From skull base to hard palate. Okay, talking about the region of hypopharynx, that is what? That is, one is nasopharynx or epipharynx. It is from skull base to what? Skull base to what? Skull base to our hard palate, right? The line, right? The line going from hard palate. And another is our oropharynx. Talking about oropharynx, from it extends from hard palate to what? Hyoid bone, right? Hyoid bone. And talking about what? Talking about the last one, that is laryngopharynx, right? Laryngopharynx or hypopharynx. It extends from what? Hyoid bone to lower border of cricoid cartilage, right? These are what? These are the region, right? Division of pharynx and the vertebra level. The lymphatic drainage of pyriform fossa is, now talking about the lymphatic drainage of pyriform fossa, where does it drain, right? It drains into upper deep cervical node, right? Upper deep cervical node. Now pyriform fossa is richest in lymphatic in hypopharynx. It drains into upper deep cervical lymph nodes, right? Similarly, now, okay, now moving to our next question. Okay, the node of Rovinier, right? The node of Rovinier are lymph node present in retropharyngeal space of Gillette, right? Retropharyngeal what? Space of Gillette. Now, okay, Gillette space is retropharyngeal space, right? Retropharyngeal space. Now here talking about, okay, retropharyngeal spaces, right? Now let's talk something about what? Retropharyngeal spaces. Now I've already said retropharyngeal space, these are also called what? These are also called what? Our Gillette spaces, right? These are also called Gillette spaces. Now the more point is that the retropharyngeal space, right? It is the space lying between what? Buccopharyngeal fascia, right? Fascia overlying pharyngeal constrictor muscle and what? Alar fascia, right? Now between, okay, let me make one diagram for you right here. Okay, now here this is what? This is our vertebrae. Let's say this is our vertebrae. Now just in front of vertebrae, what we have? We have prevertebral. Okay, what is this? This is our prevertebral fascia. Now just front of it, what we have? We have another fascia. What is that? That is alar fascia. Alar fascia. Prevertebral fascia, alar fascia, and then what we have? Next one. Next is our what? The next is our, what is this? This is buccopharyngeal fascia. So just what? Just align with vertebra, what we have? Just front of vertebra we have got prevertebral fascia. Then what we have? We have got alar fascia, and then what we have got? We have got what? We have got buccopharyngeal fascia. Now talking about retropharyngeal space, this retropharyngeal space is this space, right? This is space between buccopharyngeal fascia and alar fascia, right? Buccopharyngeal space and alar fascia, it is what? It is our retropharyngeal space, right? Now this is space, now this is retropharyngeal space. Now, okay, now what about this space between alar fascia and prevertebral fascia? Between alar and prevertebral fascia, this is our danger space. What is this? Danger space, right? And talking about this fascia, right? What is this? Prevertebral space. This is prevertebral spaces behind, just in front of vertebrae. So we are clear about what? Prevertebral space, danger space, retropharyngeal space, right? These are the space. Now this retropharyngeal space, it is called space of Gillette also. Gillette, right? Gillette. Now here what we have? Now here okay, now here in now from this retropharyngeal space, right, we are going to talk about different MCQs. Now here gelatin space is, it is retropharyngeal space. Danger space is located between, okay, I have already said danger space, right? Danger space, it is between what? Between prevertebral fascia and alar fascia, right? So 12 number, it is B is the right answer, right? B is the right answer. Okay, now nasopharynx is visualized in OPD by, now how is nasopharynx visualized? Now nasopharynx is visualized by, right, by both PNS mirror and tongue depression, right? Okay, to examine nasopharynx or postnasal space in OPD, posterior rhinoscopy is done. What is done? Posterior rhinoscopy, right? Rhinoscopy is done. Now here talking about this PNS mirror, with the help of tongue depressor we depress the tongue, and then PNS mirror is passed behind the uvula, right? The glass surface of PNS mirror is pre-warmed, right? The pre-warmed, right, to avoid mist formation due to patient's breath during examination. Wilder's group of lymph node do not include. Now here, right, Wilder's ring. Now talking about Wilder's ring, Wilder's group of lymph node consists of what? Several structures. Now out of those structures, I would like to mention some of the points. Now here this is our Wilder's ring, right? There is outer ring and inner ring. Okay, this is our what? This is our what? Wilder's ring, right? It consists of outer and inner, but here we are going to talk about inner only. Inner we have got what? We have got adenoid, right? What we have got? We have got adenoid. What is this? This is adenoid, right? Adenoid. And just okay, behind what we have got, what are these structure? These are eustachian tube opening. Now just above eustachian tube opening we have got what? We have got tubal tonsil, right? Tubal tonsil. Now laterally what we have? Laterally we have got these. Now what are these? Okay, these are our palatine tonsil. Now just in middle what we have got? We have got these structures, right? What are these? These are our, what are these structure? These structure are our what? These are our lateral pharyngeal band, right? And in between we have what other structure? What are these in between? In between we have posterior pharyngeal wall nodules. What? Posterior pharyngeal wall nodules, right? And talking about below, right, here what we have got? We have got what? Now here we have got lingual tonsils, right? Lingual tonsils. Okay, now talking about submandibular lymph node, right? Can we see submandibular lymph node here inside? No, we can't see. Tonsils, yes, there are many tonsils. This is what? This is tubal tonsil, right? This is what? This is palatine tonsil, right? Similar, these are what? These are lateral pharyngeal band, right? These are posterior pharyngeal wall band, right? Okay, now here tonsil are seen. Lingual tonsil, yes, these are seen here. Adenoid, yes, these are seen. So the submandibular lymph node is not seen here. Parapharyngeal space is known as, okay, now parapharyngeal space. Now talking about this parapharyngeal space, it is called lateral pharyngeal space and pharyngobacillary space, right? Parapharyngeal space is also called known as lateral pharyngeal space or pharyngomaxillary space, right? Okay, now moving further, what we have is, we have next question, that is the medial bulging of pharynx is seen. The medial bulging of pharynx is seen where, right? It is seen in parapharyngeal abscess, right? It is seen in parapharyngeal abscess. Okay, now this parapharyngeal abscess, right, talking about parapharyngeal abscess, right? Parapharyngeal abscess is the parapharyngeal space is the space just lateral to what? Just lateral to pharyngeal wall, just lateral to pharyngeal wall, right? It is divided into this parapharyngeal space. Parapharyngeal space is divided into what? It is divided into anterior and posterior, but posterior compartment, right? Posterior compartment. Now while talking about this anterior and posterior compartment of parapharyngeal abscess, right, or lateral pharyngeal abscess, right? Now these are what? These, one of them, anterior compartment, right? It is related to tonsillar fossa, right? And is medial, and is related to medial pterygoid muscle. So tonsillar fossa and medial pterygoid muscle. But talking about posterior compartment, here we have got what? We have got every vessels and nerves like carotid artery, right, jugular vein, 9, 10, 11 and 12th cranial nerve, along and sympathetic trunk, right. These are the structure passing through posterior posterior compartment. So medial bulging of pharynx, right, medial bulging of pharynx, pharynx is seen in parapharyngeal abscess, right. It is the feature, right. Tonsil is being brought to midline, right, pushing tonsil to middle, right. That is what, that is parapharyngeal abscess. Trismus in parapharyngeal abscess is due to spasm of, now talking about the trismus, right. Trismus is due to spasm of medial pterygoid muscle, right, medial pterygoid muscle, right. Here there will be the triad of symptoms in the case of parapharyngeal abscess. That is what is one thing, that is prolapse of what? Prolapse of tonsil, right, prolapse of tonsil and tonsillar fossa. That is one. Another is trismus, right, trismus due to medial pterygoid muscle, right. Another is external swelling behind the angle of what? Jaw. There will be swelling externally present behind the angle of jaw, right. Okay, and that will cause what? Odenophagia. So here trismus is feature of due to spasm of medial pterygoid. During true regarding nasopharynx, right, Vesibian ridge is formed by stylopharyngeus. Now fossa of rigid molar correspond to internal carotid artery, right. Okay, now here true, this is what this is the true statement, right. The fossa of rigid molar correspond to what? Correspond to our internal carotid artery. The fossa of rigid molar lie in lateral wall of nasopharynx, right, lateral to lateral pharyngeal wall of nasopharynx and oropharynx, right, is parapharyngeal space through which passes the internal carotid artery. And another right true statement is lower border lie in level of soft palate, right, lower border lies in level of soft palate. And talking about the passavant ridge is formed by palatopharyngeus, right, this passavant ridge is formed by palatopharyngeus, not stylopharyngeus, right. Okay. Okay, now moving to our next question. The next question is sinus Morgagni lie in, right. Talking about sinus Morgagni, it lies between skull and superior constrictor muscle, right. It lies between the base of skull and superior constrictor muscle, right. Okay, now talking about the sinus Morgagni, right. Okay, now the next question is adenoid are also called, these are also called what? These are also called our nasopharyngeal what? Tonsil, right, nasopharyngeal tonsil. Okay, there are several names, like for the palatine tonsil, these are also called what? Phaseal tonsil, right, these are also called phaseal tonsil. And here adenoid, these are also called Lascaux tonsil, right, Lascaux tonsil. Okay, Gordlach tonsil, what is the Gordlach tonsil? That is our tubal tonsil, is the Gordlach tonsil, tubal tonsil, right. Now palatine tonsil, that is phaseal tonsil. Okay, space of Gautier, retropharyngeal space, we already did it. The nerve carrying taste sensation from circumvallate papillae, right. Now here in this structure we can see what are these are the circumvallate papillae. Now what is carrying? Glossopharyngeal nerve is carrying, right. What is carrying here? The glossopharyngeal nerve is carrying from circumvallate papillae. Which type of epithelium of, what is the type of epithelium in adenoid, right? The type of epithelium in adenoid is what? Our what? Pseudostratified ciliated columnar epithelium, pseudostratified ciliated columnar epithelium, right. Okay, epipharynx is also called epi, right, that is nasopharynx. Passavant ridge is formed by, it is formed by passavant ridge, we already talked before. It is formed by palatopharyngeus and superior constrictor, right, palatopharyngeus and superior constrictor. Lower limit of retropharyngeal spaces, right. Now here talking about the lower limit of retropharyngeal space, it is bifurcation of trachea, right. Retropharyngeal space, the lower limit is bifurcation of trachea. In carcinoma base of tongue, pain is referred to ear through. Always the referring is done by glossopharyngeal nerve, right. That was supplying what? That is glossopharyngeal nerve supplies what? The base of tongue, right, and it also supplies the ear. That's why. Now moving toward question number 29, right. 29. The marked structure in the Walder's ring is, we have already said what are these? These are adenoid, these are Eustachian tube opening, right. These are what? These are tubal tonsil, these are palatine tonsil, right. These are what? These are lingual tonsil. What is the next name for tubal tonsil? That is Gordlach tonsil, right. Talking about okay, there are other names also, right. Okay, and we had got nasopharyngeal tonsil, that is the another name for what? Another name for adenoid, right? Adenoid, then another name for adenoid. Okay, now moving further, we have what? We have next question, that is the structure passing through, the structure that is passing through what? The structure that is passing through area marked 1. What is marked 1? Okay, here, right? Showing the pharyngeal musculature all except the area marked 1 in the figure below, showing the pharyngeal musculature are all except, right? Okay, now here, now talking, okay, now here tensor tympani is the right answer, right? Here the structure passing through area marked 1 in the figure below, showing the pharyngeal musculature are all except, right? Are all except. Now here station tube, it is also right. Ascending palatine artery, it is also right. Levator palatine is also right, but tensor tympani is not right. Okay, right? Sinus morgagni, here it is talking about the structure passing through sinus morgagni, right, between superior constrictor muscle and skull base. Now here the structure passing are from P, we can remember as PALATE, right? From P we have what? We have palate, right? Palate. From palatine artery. From L we have what? Levator valli, right? Levator valli palatini. And from T we have tensor valli palatini, right? From E we have what? Station tube, right? So station tube, it is what? It is passing through, right? Station tube is passing through, right? And talking about what? Tensor tympani, there is no such thing tensor tympani yet, right? So what? Artery, right? We are talking about ascending palatine artery is passing through it, right? From L we have what? Levator valli palatini also. So tensor tympani is not related to what? Sinus what? Morgagni. The most common site of origin of diverticulum of pharynx in the barium shallow given below is, okay. Now the most common site of diverticulum of pharynx is what? We know that is Zenker, that is the most common diverticulum is Zenker's diverticulum, and it is through what? Gallien's and dehiscence, right? The cricopharyngeus and thyropharyngeus, what? There will be what? There will be between thyropharyngeus and cricopharyngeus, right? Okay, that is the right answer. The space through which the arrow is passing in the figure. Okay, now here the space through which that is, okay, now here as you can see this is what? Here we can see this is vertebra, right? Now here this red one, what? This red one layer, it is buccopharyngeal fossa, fascia, right? Buccopharyngeal fascia. And here this is what? This is alar fascia. Now between buccopharyngeal fascia, right, and alar fascia, right, what we have got? We have got our what? Retropharyngeal space. So this space, right, this space which is passing through buccopharyngeal fascia and alar fascia is our retropharyngeal space. The nerve and vessel shown in the figure below are passing through. Nerve and vessel shown in the figure are passing through. Now here the vessels, these are the vessels and these are the nerve. Now from where they are passing, right? Now they are passing through what? Okay, we have already said the vessels and nerve, right? They all pass through what? The posterior compartment of parapharyngeus space, right? So the right answer is parapharyngeal space, or to be more concise, they pass through what? Posterior compartment, right? From anterior compartment is only related to fossa of tonsil, right, and tonsillar space. Okay, moving to our next question. Not true about the area marked in the given feet below, right? Okay, now here this is what? This is left sided pyriform fossa, right? And this left side, now this left sided what? Pyriform fossa, the most common site for carcinoma in Plummer-Vinson syndrome is postcricoid, right? Postcricoid. Now there is no such importance. Okay, talking about this is what? This is left side of pyriform fossa. Now here not true is that it is lateral channel for passage of food. Yes, it is most common site for carcinoma in Plummer-Vinson. No, because Plummer-Vinson, the most common site is postcricoid region, right? But here the structure shown is what? Pyriform fossa. It is not the right answer. It is the site of foreign body allotment. Yes, it is part of hypopharynx. Yes, 3P are the site of part of hypopharynx. Pyriform fossa, that is posterior pharyngeal wall, that is postcricoid region, and out of which postcricoid region is the what? The site of Plummer-Vinson syndrome. The area marked in the given picture is, what is this? We know that is what? That is circumflate, right? Papillae, right? And it is supplied by what? Glossopharyngeal nerve. Which of the following the pain from the given part of tongue is referred to? Okay, here it is talking about anterior, but one, okay, anterior to thought, right? Okay, now here the pain refer from this part of tongue is referred to ear by. I've already said it is what it is, what it is. Now here from this region, that is lingual nerve, right? Lingual nerve, because it is anterior to thought. The tongue muscle are derived from, what are they derived from? They are derived from occipital myotomes. So this is all about what? This is all about MCQ from what? From our anatomy and embryology of oral cavity and pharynx. Now the MCQs from which we are going to cover MCQ is from adenoid hypertrophy and Thornwald's bursitis, right? Now before getting into it, okay, now let's go direct into the question. The first question is Thornwald cyst. Now what is Thornwald cyst? It is nasopharyngeal cyst, right? Or okay, now here what is Thornwald cyst is, if you, okay, now here there is what? There is nasopharyngeal bursa, right? Epithelium lined rays found within the adenoid mass, right? Nasopharyngeal bursa is there, right? Sometimes an abscess can be formed in a bursa, and that is what we call Thornwald's disease, right? Okay, this there is what Retique's pouch, there is what? Nasopharyngeal bursa, right? Nasopharyngeal bursa. Now if this nasopharyngeal bursa is what? If it is blocked, right, blood, that is Thornwald disease, right? Now this nasopharyngeal bursa, it is also what? It is the site for notochord attachment in intrauterine life, right? It is a midline recess, right? Okay. Thornwald abscess is false, right? Now, talking about Thornwald abscess, the false estimate about Thornwald abscess is, what is it? Now here there will be what? There will be antibiotic is used, right? That's right. Marsupialization is done, that's right. Removal of cyst is done, but antitubular treatment is not provided. So it is the false statement, right? It is the false statement. Now moving further, adenoid are also called nasopharyngeal tonsil. Okay, these are called nasopharyngeal tonsil. Talking about palatine tonsil. What are these palatine tonsil also called? These are also called phacial tonsil, right? Phacial tonsil. These are the same thing, right? And talking about lingual tonsil, there is no such specific name, but adenoid tonsil or nasopharyngeal tonsil, these are also called what? These are also called Luscas tonsil. Luscas tonsil, right? Similarly, talking about what? Talking tubal tonsil, these are also called Gerlach tonsil. What is called? Gerlach tonsil. The 5-year-old child with recurrent sinusitis, the cause is, okay, since it is what? The age is small, so here what you can say is it is because of adenoid hypertrophy, right? Adenoid hypertrophy. Now here adenoid, right? Regarding adenoid, true is there is failure to thrive, okay, that is the true statement. Mouth breathing is seen, okay, that's also seen. CT scans should be done to assess size, no. High-arc palate is seen, right? So A, B and E are the right answer. Immediate surgery for minor symptoms is not done, right? So talking about what? Talking about adenoid hypertrophy, right? Adenoid hypertrophy, the treatment is what? Immediate surgery is not the treatment. Now here what we do in treatment is we provide breathing exercise, right? In general we provide breathing exercise. In medicine we provide what? Antihistaminic, decongestant nasal drops, right? In surgery we do adenoidectomy, right? Adenoidectomy, okay, but that is not done immediately. Okay, now talking about true about enlarged tonsil, enlarged adenoid. Okay, mouth breathing is seen, yes. Failure to thrive is there. High-arc palate, all, yes, all. So here what you can say here is, okay, there is one important what? Symptoms, right? Talk about the symptoms of enlarged adenoid. What you can say here is there are what? Nasal symptoms, right? There are nasal symptoms, right? There are what? In nasal symptoms, what we have got nasal obstructions, right? Because of nasal obstruction there will be mouth breathingness, right? Failure to thrive, feeding and sucking difficulty, and there is mouth nasal discharge also, right? And nasal discharge due to choanal obstruction of or chronic rhinitis. Child has wetty bubble nose, right? Bubble nose. So here nasal obstruction, nasal discharge, both are there in the case of nasal symptoms. Now talking about what? Talking about other symptoms, sinusitis is present there. Sinusitis, right? Most commonly chronic maxillary sinusitis. Epistaxis is seen there. Epistaxis is seen, right? Voice change, one of the most important feature, that is rhinolalia, right? Rhinolalia clausa. Rhinolalia, CLAUSA. Rhinolalia clausa, right, and voice loss, nasal quality due to nasal obstruction, right. These are what? These are the nasal symptoms, right. Nasal symptom: nasal obstruction, nasal discharge, sinusitis, epistaxis, voice change, right. Talking about what? Talking about oral, right. Oral, what happens in oral symptoms? There will be tubal obstruction, right, blocking of distension tube leading to retracted tympanic membrane, and conducting hearing loss will be there. Now after that it will follow what? It will follow what? Acute otitis media, right. Acute otitis media. Similarly, chronic otitis media, chronic suppurative otitis media will be there. There will be serious otitis media also. So these are what? These are the oral symptoms, right. Okay, these are the oral symptoms. So we talked about nasal symptoms, we talked about oral symptoms also, right. There is one important thing, that is adenoid phase in here also, so we'll be talking about that also. Now here, true about adenoid: mouth breathing, yes. Is failure to thrive, yes. High arch palate, yes. All of the above are right. Adenoidectomy is contraindicated in. Now where it is contraindicated? It is contraindicated in cleft palate, not lip, cleft palate. So here, large adenoid, it is done. In large tonsil it is done. Cleft lip also it is done, right. Talking about what? The contraindication in cleft palate or in soft mucosal palate, soft mucous palate, right. At that time it is what? It is contraindicated, along with hemorrhagic diathesis, acute infection of upper respiratory tract. It is what? It is contraindicated. Adenoidectomy contraindicated in bleeding disorder, we have already said, right. In other conditions like here in ear SOM, right, in ASOM, CSOM, right. These are what? Here it is indicated, right. Adenoid hypertrophy with symptoms, treatment is all except. Now with the symptom, the treatment is all except. Nasal decongestant, yes we do, right. Okay, we do the nasal decongestant, right. We do provide antibiotics. Beta 2 agonist, we don't provide beta 2 agonist. Adenoidectomy, yes we do. Surgical treatment is our adenoidectomy, right. Here we don't provide beta 2 agonist. Indication for adenoidectomy in children include all except recurrent upper respiratory tract infection. Okay, recurrent upper, yes it is also the indication. Recurrent middle ear infection, yes. Chronic serous otitis media, that's right. Multiple adenoid, that's not right. Multiple adenoid are no, what? These are no anatome, right. Adenoid tissue normally have vertical ridges on surface which make it appear multiple. That is why the term adenoid instead of adenoid is used, right. Adenoid, so we use adenoids. Adenoidectomy with grommet insertion is treatment of choice for. We all know grommet insertion is done in what? SOM, serous otitis media. What we do? How the incision are made in serous otitis media? Anterior, inferior, right. Inferiorly the incision is made. Now moving to our next question. The next question is the management of 6-year-old child with recurrent URTI with mouth breathing and failure to thrive with high arch palate. The impaired hearing is, you know, if there is children with what? With recurrent URTI, mouth breathing, failure to thrive with high arch palate. Here it is what? It is, here it is talking about adenoid hypertrophy, right. Hypertrophy, that is adenoidectomy with grommet insertion. Can we do here? I think we can do here, because the child is what? Child is suffering from URTI also and impaired hearing also. So adenoidectomy with grommet insertion. Rhinolia clausa, yes we said, we talked in what? Nasal symptom, right. Is associated with which of the following except, right. Adenoid, it is, right. It is associated with adenoid also. It is associated with nasal polyp or not? Yes. Allergic rhinitis, yes. But palatal paralysis, it is not associated with palatal paralysis. Instead, palatal paralysis lead to rhinolalia aorta, right. Aorta. In patient with hypertrophic adenoid, the voice abnormality that is seen is, we have already said, in adenoid hypertrophy, that is rhinolalia clausa. Rhinolalia aorta is a feature of palate paralysis, right. The complication of adenoidectomy are all except hyponasality of voice. Okay, it can be, right. Hyponasality of voice, no, it cannot be, right. Hyponasality of the voice is not the complication of adenoidectomy, right. Pharyngeal insufficiency, yes. Hemorrhage, yes. Gracile syndrome, that's right. So here all are what? All are the symptoms, right. All are the complication except hyponasality of voice, right. Okay, now talking about the complication of what? Adenoidectomy, right. Hemorrhage is right. Hemorrhage is the most important complication. Similarly, injury to what? Injury to eustachian tube opening, right? Injury to pharyngeal musculature and vertebrae, right? Grissel syndrome. Grissel syndrome is also the important complication in which patient complains of neck pain and develop torticollis, right? Head tilt in odd angle. Similarly, velopharyngeal insufficiency, nasopharyngeal stenosis recurrence, right? So these are also what? These are also our complication of adenoectomy. Out of these, the most asked question is that there is velopharyngeal insufficiency, in which there is a speech problem after adenoectomy, right? And it will call hypernasality. It will call what? Hypernasality. Since it is causing hypernasality, so the hypernasality of speech is not the right answer. So in velopharyngeal insufficiency, right, there will be what? Change in voice, that is hypernasality. So here hyponasality is not the right answer. Children with adenoid hypertrophy and blockage of eustachian tube has further risk for, right? Okay, children with adenoid hypertrophy and blockage of eustachian tube has a further risk for. So here it is going toward what? It is going toward cholesteatoma. It is primary acquired cholesteatoma. Secondary acquired cholesteatoma is always secondary to perforation. Dots sign is seen in. Okay, talking about the Dots sign, right? In antroconal polyp, right, ear is in posterior superior, right? Posterior superior region, and that is the Dots sign or crescent sign, right? So here the antroconal polyp is the right answer. Antroconal polyp, right? Antroconal polyp. So in antroconal polyp there will be what? There will be ear in posterior superior region, right? Posterior superior region, right? And here we are talking about what? Radiograph, right? Radiograph sign, and that is what? That is Dots sign or crescent sign. What type of epithelium is of adenoid? We have already said, we have done it earlier. Pseudo-stratified ciliated columnar epithelium. All of the following are feature of enlarged tonsil except serous media, yes. Nasal obstruction, yes. Failure to thrive, yes. Orinophagia, it is not the feature of enlarged tonsil. Speech problem after adenoidectomy is due to, we have already said, velopharyngeal insufficiency, that will cause hyponasality, right? Hyponasality. And talking about the next question, that is in 5-year-old child after adenoectomy developed hypernasality and nasal regurgitation of food, that could be the cause of, yes, velopharyngeal insufficiency, right? Okay, a 6-year-old child presents with recurrent URTI, right? Mouth breathing and high arched palate and impaired breathing. The appearance is known as, that is what? That is adenoid faces, right? That is what? That is our adenoid faces. Now, talking about adenoid faces, okay, how to remember adenoid faces? What we have here is, okay, let's start from C. It consists of crowded teeth, right? Crowded teeth. It consists of crowded teeth. Now from C. From D, what we have? From D, what we have is dull expression, right? There will be dull expression. From E, what we have? From E, we have elongated face. As you can see, the face is what? Elongated face will be there, right? From F, what we have? Yes, elongated face. From E and F. EF. From G, what do we have? That is guys aproxia, right? Aproxia. What is guys aproxia? That is lack of concentration, guys aproxia. Now E, F, G. From H, what we have? Pulmonary hypertension, right? Hypertension. So we started from C, that is crowded teeth. From C, D, what we have got? From D, dull expression. C, D, E, elongated face. F also there. G, guys apraxia, right? Then G, H, pulmonary hypertension. So these are what? These are the feature of what? Our adenoid faces, right? Adenoid faces. Now moving to our next question. A 5-year-old child present with recurrent URTI with mouth breathing, snoring, X-ray STN is given below. The child will be advised for adenoectomy if the following are present except recurrent upper respiratory tract infection, yes we do. Recurrent middle ear infection, we do. Sleep apnea and hypernasality, right? So here hypernasality is what? Here in the case the child will be advised for adenoectomy for all the cases, not for hypernasality. Pharyngeal bursa give origin to pharyngeal bursa. We have already said, right? Thorn-walled cyst, right? Thorn-walled cyst. There will be persistent what? Pharyngeal bursa, right? There will be blockage in pharyngeal bursa, right? Then at the time pharyngeal but cyst will take place. So here these are all the questions about what? About our what? thorn wall cyst, and adenoid hypertrophy. The portion from which we are going to solve MCQ is from angiofibroma, right? From angiofibroma. Now, okay, angiofibroma. What is the next name for angiofibroma? It is nasopharyngeal fibroma, juvenile nasopharyngeal angiofibroma. Right now, the most common site for origin of nasopharyngeal angiofibroma. What is the most common site? That is sphenopalatine foramen. Right. Now, talking about the sphenopalatine foramen specifically, right? The origin is where it is from, right? It is originated from what? From the posterior part of nasal cavity close to superior margin of sphenopalatine foramen, right? Sphenopalatine foramen. Nasopharyngeal angiofibroma. What is it? It is benign or malignant condition, right? Now it is what it is, the what? Benign condition, right? Benign condition. 10-year-old boy has unilateral nasal obstruction, right? Recurrent profuse epistaxis, swelling over the cheek, and diagnosis is now here. Now talking about what etiology, right? Etiology of nasopharyngeal angiofibroma, right? Now it is what? It is mainly testosterone dependent, right? Testosterone dependent, right? Now so the age that is mainly concerned right here is about the adolescent male, right? Adolescent male, that is from 10 to 14 years of age. So here the child is 10-year-old, unilateral nasal obstruction, recurrent profuse epistaxis. And talking about the clinical feature, now here there will be profuse and what? Recurrent epistaxis, right? Another thing is that, and there will be progressive nasal obstruction also. Conducting hearing loss will be also there, right? And there will be mass in nasopharynx also, right? So here it is obviously what? Angiofibroma is the right answer, right? Angiofibroma. In angiofibroma of nasopharynx, all are correct except common in female. No, that's not right, right? All are correct except. So here we have already got the answer, that is in question number 4, right? What we have got? Yes, it is not common in females. But talking about other thing, the most common presentation is epistaxis. Why the epistaxis is most common in presentation? Because here there will be what? There will be what? The endothelium of what? The endothelium lining consists of no muscular coat, right? No tunica media, so it can't contract here. So bleeding cannot be controlled by adrenaline. So what is going on? Maximum blood will be what? There will be maximum blood, right? Blood loss, right? Epistaxis will be there because no tunica media, no muscular coat, no contraction. That's why. And another thing is arise from lateral wall of nasopharynx, it is sphenopalatine foramen. That's right. In late case, frog face deformity will be seen. Yes, frog face deformity will be seen, right? Why? Because on entering these mass, on entering the inferior orbital feature, right, destroy the apex of orbit, right? It will cause broadening of what? Nasal breeze, right? And it will give frog face deformity. Angiofibroma bleed excessively because I have already said it lacks what? Contractile component, that is tunica, what? Tunica media, the muscular coat, right? Muscular coat, right? Question number 5, the lack of contractile component. The clinical feature of nasopharyngeal angiofibroma are present in 3rd to 4th decade. No, that's not right, right? That's not right. Adolescent male, that's right. Epistaxis and nasal obstruction are cardinal symptom. Okay, epistaxis and nasal obstruction, these are. Radiotherapy is a treatment of choice. No, here we do what we do here is we simply do surgery, right? Arise from posterior nasal cavity. No, sphenopalatine foramen, that is lateral, in lateral wall, right? So here B and C are the right answer. A 14-year-old boy presented with repeated torrential epistaxis, swelling in the cheek. Which of these statement may be correct? Diagnosis is nasopharyngeal angiofibroma. That's right, right? CCT should be done to see the extent. That is also right, because when we see the extent, right, on seeing the extent, we just divide it into different stages, right? Okay, high propensity to spread via lymphatics. Okay, now this C option is not right, right? It will not. What here? There will be what? There will be no spreading through lymphatics. Now D, arise from roof of nose. That's also not right. It arises from what? A roof of nasopharynx, not from nose. Surgery is a therapy of choice. That's right. So here option number A, B and E are the right statement. True about juvenile and nasopharyngeal angiofibroma. What is true about this condition? Okay, now here the true statement is surgery is the treatment of choice. That's right. It is malignant. No, it is not. It is benign condition. So A is the right answer. Let's see other options also. Increase the incidence in female. There is increased incidence in female. No, that's not right. In male, biopsy is done for the diagnosis. It is never done. Right? Why it is never done? Because while doing the biopsy, there will be profuse bleeding. right? So before surgery also we do embolization of internal maxillary artery, right? Okay, so it is also not right. Holman-Miller sign is positive, that's right. What is Holman-Miller sign? Okay, now as there is origination from sphenopalatine foramen, it will what? It will extend to what? Pterygopalatine fossa, right? It will extend to pterygopalatine fossa, and also to what? Infratemporal fossa, right? Now these structure lie just behind what? Our maxillary sinus, right? Maxillary sinus. Now as these structure, as they will be invading to these structure, they will do anterior, but they will push this maxillary sinus, this posterior wall of maxillary sinus. As they will push posterior wall of this maxillary sinus, there will be the peculiar finding, that is anterior bowing of this posterior wall of maxillary sinus, right? And that is what Holman-Miller sign is, right? This is what this is peculiar, right? CT scan finding, right? Pathogenomic of angiofibroma. Okay, that is what it is. So it is also positive. So option number A and E are the right answer. True about nasopharyngeal angiofibroma is commonly seen in girls? No. Hormone etiology? Yes. Surgery is the treatment of choice? That's right. Radiotherapy can be given? Okay, right? Okay, it can be given. Recurrent is common? Recurrence is common. So the right answer is B, C, D and E. The most appropriate investigation for angiofibroma: angiography, MRI, CECT, plain X-ray. We have already said the CECT scan, the finding Holman-Miller sign, right? 10-year-old boy present with nasal obstruction and intermittent profuse epistaxis. He has firm pinkish mass in nasopharynx. All of the following investigations are done in the case except what we do CECT. That's right. We don't do biopsy. It is contraindicated. So it is the right answer. An 18-year-old boy presented with repeated epistaxis. There was mass extending into nose and nasopharynx, right? It was decided to operate him, right? All of the following are true regarding the management except requires radiotherapy before surgery. Is it required? No, it is not required. This is not the right answer. So it is the answer. A lateral rhinotomy approach may be used. That's right. There is the approach called lateral rhinotomy approach, right? Lateral rhinotomy approach. That is extended lateral rhinotomy. That can be through facial incision or deep globing approach. Transpalatal approach, yes, it can be used. Transmaxillary approach, as it can be used. Palatine plus sublabial, extended lateral rhinotomy, extended Danker's approach, intracranial, infratemporal, endoscopic, transmaxillary and maxillary swing approach are the approaches that can be done according to what? According to the origin and extension of angiofibroma. Treatment of choice in angiofibroma is surgery and radiotherapy. What we do? We do both things, right? We do both things, but the treatment of choice, when it's asked about treatment of choice, that is our surgery is the best thing, right? And radiotherapy is indicated in angiofibroma only when tumor has intracranial extension, right? In intracranial extension. Frog face deformity of nose is caused by, we know, angiofibroma or nasopharyngeal angiofibroma, right? A 2-year-old child presented with unilateral pink nasal mass. Most important investigation prior to undertaking surgery is most important investigation. What is the most important investigation? That is contrast what? Our CT scan. Antral sign is seen in now. What is this antral sign? Right? Okay. Antral sign is seen where? It is seen in juvenile angiofibroma, right? Okay. Now talking about, okay, we'll go into antral sign also, right? Okay, moving toward next question, that is question number 16, right? Radiotherapy is used in treatment of angiofibroma when it involve, well, already said where? When it involve cranial fossa, right? Middle cranial fossa. Which of the following is not true for juvenile angiofibroma? Biopsy for diagnosis? Yes, it is not true. It is contraindicated. Benign tumor? Yes. Surgical exclusion? Yes. Typical occur in second decade? That's also right. Right? It says to be nasopharyngeal angiofibroma best treated with. Now, how it is treated? We all know the treatment of choice is surgery, right? Antral sign is seen in. Now, antral sign is seen in where? In angiofibroma, right? In angiofibroma, right? Okay. Now, this antral sign, it is what? It is Holman-Miller sign only, right? Holman-Miller sign only. True about nasopharyngeal fibroma. Arise from fossa of frozen molar? No. Benign but locally invasive? That's right. Radiotherapy is treatment of choice? No. Caused by EBV? No. So here the answer is benign but locally invasive. Juvenile nasopharyngeal angiofibroma is supplied by, how it is supplied? Juvenile nasopharyngeal angiofibroma, it is supplied by what? Internal maxillary artery. Internal maxillary artery. So while doing surgery, the initial step was what? To ligate, right? To embolize internal maxillary artery, right? To embolize internal maxillary artery. So the next question is, okay, given CCT showing an enhancement, right? Enhancing mass in nose, spinopalatine foramen, infratemporal fossa of 18-year-old male presenting with recurrent epistaxis, nasal obstruction and swelling of cheek. It should be managed by following step, right? Okay, here as you can see, what the maxillary, the posterior wall of what maxillary sinus is being pushed forward, that is Holman-Miller sign. It should be managed by all except surgical excision. Yeah, that's right. Preoperative surgery. Okay, preoperative radiotherapy, it is not right, right? It is not right. Preoperative embolization, yes, internal maxillary artery, right? Okay, biopsy is contraindicated, that's also right. A 13-year-old boy with unilateral nasal obstruction and recurrent epistaxis, CCT showing an enhanced lesion in nose with minimal extension to sphenoid sinus and no lateral extension. The Radowski stage, what is the Radowski stage, right? Okay, it is when, okay, enhancement of lesion in nose with minimum extension to sphenoid sinus and no lateral extension, right? Here, now talking about the stages, right? Now here the right answer is 1B. Now what is 1B? Okay, now talking about the stage 1, what is stage 1? Tumor limited to nasal cavity and no bone, what? No bone destruction, right? And talking about okay, talking about 1A. Okay, now here we have got one okay, we have got 2. The 2 is divided into A and B. Now there are different what classification, but here we're talking about 2A. There is extension through what? Our through spinopalatine foramen, right? Extension through spinopalatine foramen. And 2C, what we have? We have involving pterygopalatine fossa or what? PNS, right? And talking about 2C, right? 2A, B and C, and C is when there is involvement of inferotemporal fossa, right? So here in 2A, 2B, 2C, 2A, right? There is what? There is extension through spinopalatine foramen, right? 2A, and 2B involving pterygopalatine fossa, right? Pterygopalatine fossa and infratemporal fossa in 2C, and 4 is cavernous sinus, optic chiasma and pituitary fossa when there is involvement of these things. But here it is what? It is here there is extension to nose and minimal extension to sphenoid sinus also, right? No lateral extension. So 1B is the right answer. So this was all about what? This was all about questions from what? Our angiofibroma or what? Juvenile nasopharyngeal angiofibroma. Now the MCQs that we are going to cover is from the topic of nasopharyngeal carcinoma, right? Before we talked about angiofibroma, that is what? Juvenile nasopharyngeal angiofibroma. Now what we are going to talk about? Nasopharyngeal carcinoma. Now without delay, let's begin the first MCQ, that is nasopharyngeal carcinoma is caused by. Now it is caused by, talking about the etiology, it is caused by what? It is caused by virus, right? That is Epstein-Barr virus, right? Epstein-Barr virus. Nasopharyngeal carcinoma involves, what does it involves? Okay, it involves our what? Nasal cavity, yes. Oropharynx, that's right. Piriform fossa, no. Tympanic cavity, that's right. And orbit also, right? Nasopharyngeal carcinoma does not involve piriform fossa. Rest of the structure are involved. Now the most common site of origin of nasopharyngeal carcinoma, right? It is what? It is fossa of Rosenmuller, right? The nasopharyngeal carcinoma presents as, it is presented as mass in neck, right? A 70-year-old male present with neck nodes and right-sided deafness, right? Examination reveals tall tympanic membrane. Tympanometry shows a curve B, right? B. The most probable diagnosis is, what is the most probable diagnosis? Okay, now here, now what it is showing, it is talking something about the feature of nasopharyngeal carcinoma. The what? The what? Trotter striate, right? Trotter striate. What does trotter striate include? It includes, we can memorize at NPCA only, nasopharyngeal carcinoma. From N, what we have got? We have got trigeminal neuralgia, right? neuralgia. From P, what we have got palate palsy, right? From C, we have got CHL, conductive hearing loss. Now here there is dull tympanic membrane, that is here talking about conductive hearing loss because of fluid inside it, right? And tympanometry also shows curve B, that denotes fluid within what, middle ear cavity, right? And there is node also, right sided deafness also, right? Here it is talking about what, it is talking about nasopharyngeal carcinoma, right? Nasopharyngeal carcinoma cause deafness by, okay, we already said, right, it will cause deafness by what, fluid into the middle ear cavity, that is serous infusion. Trotostride is seen in carcinoma of, already we have said, that is nasopharynx. True about trotostride is conductive deafness, that's right. Involvement of 6th cranial nerve, okay. Now involvement of 6, no, we don't talk about these things, right? Involvement of 5th cranial nerve, yeah, that's right, there is involvement of 5th cranial nerve, right? Okay, palatal palsy, that is also right, associated with nasopharyngeal angiofibroma, no. So here the right answer is R, A, C and then D, right? Involvement of 6th cranial nerve does not occur in intracranial spread in nasopharyngeal carcinoma, but it is not a part of trotostride. It is involved, but it is not part of trotostride, right? We have already said from NPCA, N was what, trigeminal neuralgia, right? That means 5th cranial nerve. P, palate palsy, right? C, conductive hearing loss. Trotostride include all of the following except mandibular neuralgia, deafness, palatal palsy, seizures is not included, right? Mandibular neuralgia, it is what, it is also related to trigeminal neuralgia. Okay, Horner syndrome is caused by, right? Now how does this Horner syndrome cause? It is caused by nasopharyngeal carcinoma metastasis, right? Metastasis of nasopharyngeal carcinoma. Nasopharyngeal carcinoma metastasis or direct extension lateral to parapharyngeal space post-styloid component lead to involvement of cervical sympathetic chain, which is known as Horner syndrome, right? Okay, now talking about the Horner syndrome, the sign, they are anhydrous, right? Meiosis, ptosis, loss of what, ciliospinal reflex, right? And then another is our enophthalmos, right? Now nasopharyngeal carcinoma most commonly involved upon intracranial spread is vagus, right? Okay, now here, now what is true about nasopharyngeal carcinoma? Most common nerve involved upon intracranial spread is vagus, that's not right. Unilateral serous media is seen, that's right. Treatment of choice is radiotherapy, that is also right. Metastasis to cervical lymph node, okay, that is also right. And EPB is responsible, we know the most common cause is EPB. Which of the following is not true regarding nasopharyngeal carcinoma? Associated with EPB, yes. Start in fossa pneumonia, that's also right. Radiotherapy is treatment of choice, that is also right. Adenocarcinoma is usual, okay. Now here adenocarcinoma is not usual, right? Nasopharyngeal carcinoma is most commonly squamous cell carcinoma, right? Squamous cell carcinoma. And if elderly patient present with unilateral otitis media, it is highly suggestive. Yes, it is highly suggestive. Treatment of choice in advanced nasopharyngeal carcinoma. What is the treatment of choice in advanced? That is concurrent chemoradiation. Treatment of nasopharyngeal carcinoma T1 and T2. Okay, it is what? It is our radiation therapy. Most radiosensitive tumor of the following is, okay, we know that is carcinoma nasopharynx. That's why the treatment of choice is radiotherapy only. All of the following statement about nasopharyngeal carcinoma are true except, right? Bimodial age distribution, that's right. That is from 60 to 70, right? And another age group is 10 to 20. Nasopharyngectomy with radial neck dissection is treatment of choice. Okay, now this is not the right statement, right? This is not the right statement. And IgA antibody to EBA is observed, that's right. Squamous cell carcinoma is the most common, that's also right. Type of speech seen in nasopharyngeal carcinoma, what is that? That is rhinolalia clausa, right? Rhinolalia clausa, which was also seen where? Which was also seen in what? Our adenoid hypertrophy. Adenoid hypertrophy. Now talking about this rhinolalia apaata, it is caused by what? Apaata, it is caused by condition leading to velopharyngeal insufficiency, right? Velopharyngeal insufficiency. And hot potato voice, it is caused produced by painful mass lesion of oropharynx, right? And horse voice, talking about horse voice, is produced by pathologies of vocal cord. Nasopharyngeal carcinoma, carcinoma is most common in, where is this nasopharyngeal carcinoma common? Nasopharyngeal carcinoma is common in Chinese group, right? Most common in China, particularly in southern state and Taiwan, right? Okay, now moving to our next question, category of non-keratinized squamous cancer of nasopharynx according to WHO is, right? That is what is the category of non-keratinized squamous cancer of nasopharynx according to WHO? That is type 2, right? Type 2. Branch of trigeminal nerve involved in trotus triadis. Okay, there was one question, that is mandibular, right? Mandibular neuralgia is there, mandibular. Which one of the following statement is true regarding nasopharyngeal carcinoma? The true statement is, what is the true statement? The true statement is, it is often arise from fossa progenular in lateral wall of nasopharynx. That's the true statement. Nasopharyngeal carcinoma is most common in which race? We have already said Chinese. Now what are these Chinese? The Chinese are Mongoloid, right? Caucasians are white group, Aryans are us, right? Trotus triad is seen in, now where is trotus triad seen? Trotus triad is seen in nasopharyngeal carcinoma, right? Nasopharyngeal. Most common presentation of nasopharyngeal carcinoma is what we have already said, that is neck mass. Which cancer has maximum propensity to spread to cervical lymph node? We already said that is nasopharyngeal carcinoma, right? In the picture present with right mass, as you can see, there is right mass not benefiting by medical management. Biopsy shows non-characterizing undifferentiated carcinoma, right? CT shows soft tissue mass arising from lateral wall of nasopharynx, right? Okay, now here the question is, not true about this tumor is, what is not true? Level 4 cervical lymph node is always to be involved. No, that's not true, right? Radiotherapy is treatment of choice, that's true. Maybe associated with unilateral serous otitis media, that's true. Associated with EPB, that's true. The marked area is the site of origin of, what is this? The marked area is the site of origin of nasopharyngeal carcinoma, that is fossa of Rosenmuller, right? 25-year-old male presented with right-sided deep cervical lymphadenopathy. Nasal obstruction is there and decreased hearing in right ear. CT shows soft tissue mass arising from lateral wall of nasopharynx. His audiogram shows 40 decibel conductive hearing loss in right ear. His tympanogram of right ear is given below. True about the condition is all except. Now here it is showing type B, right? Type B, and it is talking about right here. In right here there is what? There is what? Obviously what is there? There is serous otitis media, right? Okay, now here which is not true? True about the condition all except is. He has serous otitis media in right here, right? Biopsy should not be taken for the diagnosis. Why biopsy should not be taken? Yes, it should not be taken, right? It should not be taken. He is patient of angiofibroma because there is chance of spread, right? Patient of, no, it is not the patient of angiofibroma, right? Other sibling of the patient should be screened for the same. Yes, that's right. Genetic factor is also there. Here it is 25 years old male, right? So it is what? It is right. Here the age is suggestive factor, but here the patient is presented with what? Serous otitis media right here. So he is not the patient of angiofibroma because there is no such condition in angiofibroma. Type B curve is not seen in tympanogram. Guangdong carcinoma is Guangdong. Obviously it is similar to Chinese name, so nasopharyngeal carcinoma, Guangdong. This was all about what? The question from nasopharyngeal carcinoma. Now the topic that we are going to cover is tonsil, right? Tonsils. Now here the MCQs we are going to solve from pathology of tonsil, anatomy of tonsil. Now without delay, let's begin with the first MCQ, that is tonsil reach their maximum size by. They will reach the maximum size by 12 years, right? Tonsil are present at birth, right? And achieve their maximum size by what? Maximum size by 12 years of age, right? Okay. Now the most common cause of acute tonsillitis, what is it? It is beta hemolytic streptococcus, right? Beta hemolytic streptococcus, right? Okay. Now the commonest organism causing acute tonsillitis is streptococcus, right? Now moving further, what we have is the commonest organism. Referred pain from tonsil to middle ear is a long Okay, that is glossopharyngeal nerve, right? The arterial supply of tonsil is mainly by what is it? It is by what? Our tonsillar branch of facial nerve, facial artery. The palatine tonsil receives arterial supply from all of the following except. Okay, it will receive from what? It will receive from our what? Facial, yes, ascending palatine, dorsal lingual, but not from sphenopalatine. Sphenopalatine artery is a branch of maxillary, does not supply tonsil. It is a main artery supplying nose, and it is also called the artery of epistaxis. So why it is called the artery of epistaxis? Because it is there in what? In anterior and posterior both epistaxis, right? Okay, moving to our next question, right? What is the next question? That is, all of the following vessels supply blood to tonsil except. Now, talking about the blood supply of tonsil, we have got what? Tonsillar branch of what? Facial artery, right? We have what? Ascending pharyngeal what? Ascending pharyngeal artery, the branch of what? Branch of external carotid artery. Similarly, we have what? We have ascending palatine, ascending pharyngeal, ascending palatine, that is the branch of what? Facial artery. Similarly, we have got dorsal lingual, the branch of lingual artery. We have got descending palatine, that is the branch of what? Maxillary artery. So descending palatine, ascending palatine, right? We have got dorsal lingual, we have got what? Ascending pharyngeal, right? And tubal branch. So all of the following vessels supply blood to tonsil. Ascending pharyngeal artery, yes, it supplies the branch of external carotid artery. Tonsillar branch, that is right. Superior labial artery, superior labial is not what? It is not, right? Dorsal lingual is there, superior labial is not. So the answer is superior labial, right? Okay, it is superior labial artery is one of the what? Component of Little's area. The most commonest lymph node to enlarge in acute tonsillitis is, what is the most common? Okay, the most common is jugular and digastric. The following cause gray-white membrane on tonsil except. What is, okay, talking about the differential diagnosis of membrane over tonsil. Infectious mononucleosis, it will what? It will cause it, right? Ludwig's angina, no, it will not cause the grain membrane over tonsil, right? Now Ludwig's angina is a cellulitis of submandibular space, right? And streptococcal tonsillitis, yes. Diphtheria, yes. Patch on tonsil is not caused by Vincent angina, it will cause it. Candida, it will cause it. Streptococcus, it will cause it. Ludwig's angina, but I've already said it is what? It is cellulitis of submandibular space, so it will not cause it, right? Okay, now talking about all can cause white membrane over tonsil except Streptococcus, yes, it will cause. Candida, diphtheria, yes. Borrelia vincenti, no, it will not cause, because Vincent angina, that is grayish black, right? That is gray patch, necrotic patch is formed over the gingiva and tonsil. Now other all will cause white, right? This Vincent angina will cause black, right? Black, right? Black or gray, right? We'll call black necrotic what? Membrane. And black color patch in mouth is seen in. Now where it is seen, we have already said it is what? It is seen in what? Vincent angina, right? Vincent angina. Trench mouth is, what is trench mouth? It is our, what is trench mouth? It is ulcerative lesion of gingiva. Ulcerative lesion of gingiva is our trench mouth, right? The typical characteristics of diphtheria membrane is loosely attached and does not bleed and removable. No, it is not so. It is what? Family attached and bleed and removable. That's right, right? Family attached and bleed on removable. Vincent angina is caused by, we have already said what it is caused by, Borrelia and Fishiformis, right? Vincent angina effect, what does this affect? It affects gum, right? Vincent angina is the acute necrotizing ulcerative gingivitis spreading over the tonsil, right? It is gingivitis, so gum. All of the following are indication of tonsillectomy except foreign body in tonsil, no, it is not indication. Unilateral enlargement of tonsil with suspected malignancy, yes. Chronic tonsillitis, yes. Recurrent, yes. Recurrent quinsy, yes, it is. So talking about what? Different indication, right? There are absolute indication, right? There are what? Relative indication, right? In other operation also. Talking about absolute indication, right? There is what? Recurrent infection, recurrent infection. That is Paradise guideline. 7 or more episode in 1 year. 1 year, right? 5 or more episode, right? 5 episode per year for 2 year, right? Similarly 3 for 3 years, right? 3 episode for consecutive 3 years, 3 episode per year for 3 years, right? Okay, 7 or more episode, right, in 1 year. 5 episode per year for 2 years, right? 5 episode per year for 2 years. 3 episodes per year for 3 years, right? Similar to week or more of lost school, right? More of lost school or work in 1 year, right? This is Paradise classic, the criteria of what, of recurrent infection in throat, right? Similarly, the another is peritonsillar abscess, that is Quincy abscess. Another is tonsil causing febrile seizure, right? Peritonsillar abscess, febrile seizure, right? Hypertrophy of tonsil causing what, airway obstruction, right? Similarly, suspicion of malignancy. These are the absolute criteria. Absolute criteria are what? Recurrent tonsillitis, right? Recurrent. Then we have got peritonsillar abscess, febrile seizure, hypertrophy causing obstruction, right? And suspicion of malignancy. These are the absolute indications. Tonsillectomy is indicated in acute tonsillitis, aphthous ulcer in pharynx, tonsillitis causing rheumatic fever, physiological enlargement is indicated in. It is indicated in what? It is indicated in tonsillitis causing rheumatic fever. We have already said causing febrile or rheumatic fever. Contraindication of tonsillectomy are all accept. Now talking about the contraindication, right? There are what? There are absolute and what? Absolute and relative. Now absolute consists of bleeding disorder, right? And then we have got what? Epidemic of polio. Similar relative, what we have got is we have got hemoglobin level less than 10% gram, right? Similarly, acute upper respiratory tract infection, right? Tract infection. Similarly, what we have? Children under 3 years of age, right? And then what we have? Tonsillectomy is avoided during the period of menses. That is relative. So contraindication, that is submucosal fibrosis, is it? No, it is not contraindicated in submucosal fibrosis. Bleeding disorder, yes, it is. Bleeding disorder is what? It is relative contraindication, right? No, it is what? It is absolute contraindication. Epidemic of polio, it is absolute. Acute tonsillitis, yes, it is also what? Indicate. It is also what? Indication, contraindication, right? Not contraindication of routine tonsillectomy. Upper respiratory tract infection, it is contraindicated, right? Bleeding disorder, it is contraindicated. Diphtheria caries and cleft palate. Cleft palate, what? Diphtheria caries is what? Not a contraindication, right? Diphtheria caries. Now moving to our next question, that is contraindication of tonsillectomy. URTI, yes. Epidemic of polio, yes. Age less than 4 years, no, it is less than 3 years. Bleeding disorder, yes, it is. Chronic tonsillitis, no, it is not contraindication. So A, C and D are the right answer. Tonsillectomy is contraindicated in which of the following situation? Peritonsillar abscess, no. Acute tonsillitis, no, it is what? It is contraindicated. Yes, in acute tonsillitis it is contraindicated, right? For avulsion of glossopharyngeal knob, yes, it is what? It is indicated, not contraindicated. Suspected tonsillar malignancies, it is indicated, not contraindicated. So acute tonsillitis is where tonsillectomy is contraindicated. 5-year-old child is scheduled for tonsillectomy. 1 day of surgery, he had running nose, temperature 37.5 degrees Celsius and dry cough, right? Which of the following should be most appropriate decision for surgery? 5-year-old child scheduled for tonsillectomy, right? Now here there is running nose and temperature is 37.5 degrees Celsius with dry cough. Now what we can do here is we can just reschedule it, right? We can do surgery, we can cancel surgery for 3 weeks and put the patient on antibiotic, right? This is what we can do. Tonsillectomy is an elective surgery done under GA. Intubation during upper respiratory tract infection carries a high risk of laryngospasm and long complications. So what we do, we just cancel surgery for 3 weeks and provide antibiotic to patient. Position adapted for tonsillectomy is also adapted for the what procedure? It is also what? It is also done where? It is also done in tracheostomy, that is Rose position. In tracheostomy and in tonsillectomy, the same position is used, that is Rose position. Commonest post-operative complication of tonsillectomy, that is what? That is obviously what? Our hemorrhage, right? Post-operative complication, right? It is hemorrhage. Hemorrhage during tonsillectomy is usually from It is usually from where? It is usually from paratonsillar vein. Torrential blood during tonsillectomy is due to, it is due to what? Torrential blood is due to what? Our tonsillar artery, right? Tonsillar artery. Ramu is 15-year-old male presented with hemorrhage 5 hours after tonsillectomy. Best treatment for the patient is, that is what? 5 hours after what? Surgery, he is suffering from hemorrhage, right? So that is reactionary hemorrhage, right? That is under immediate complication, reactionary hemorrhage, right? Now what we can do here is, in this condition we can do removal of clot, application of pressure of vasoconstrictor, right? What we can do, what we can do here is re-explore immediately. We can just re-explore it immediately, right? Hemorrhage following tonsillectomy till within 24 hours is called reactionary hemorrhage and requires re-exploration. Secondary hemorrhage after tonsillectomy usually presents, okay. There is primary hemorrhage, reactionary hemorrhage and secondary hemorrhage. The primary hemorrhage is which is within intraoperatively, that is primary hemorrhage. And then reactionary hemorrhage is within 24 hours and secondary hemorrhage is within 5 to 10 days, right? So here the right answer is, what is the right answer? The right answer is our 6 days. 6 days. Hemorrhage occurring 6 hours after tonsillectomy is called, I've already said it is what? It is reactionary, right? What is it? It is reactionary hemorrhage, right? After tonsillectomy secondary hemorrhage occurred, that is what? That is 5 to 10 days, right? 5 to 10 days postoperatively. Which of the following can cause secondary hemorrhage after tonsillectomy? Which can cause secondary hemorrhage, right? Okay, that is injury to blood vessel. Okay, injury to blood vessel, no, it cannot cause, because it would have caused what? Primary or reactionary hemorrhage. Patient not taking antibiotic, yes, it can cause, right? Slippage of surgical knot, yes, no, it cannot cause, right here, right? Because it is presented mainly in 5 to 10 days, right? This would have presented earlier. Laser uvuloctomy, uvulopalatotomy is done for, it is done for what? It is done for snoring, right? Snoring. UPPP, uvulopalatoplasty, right? Is done in obstructive sleep apnea. Palatine tonsil not seen is, okay, now here palatine tonsil not seen is develops from secondary pharyngeal pouch. Yes, it is. Branch of facial artery is main blood supply, that is covered by fibrous capsulotomy, lead to ear pain due to 10th nerve. No, it is not, right? Pseudomembrane over tonsil and pharynx is caused by, it is caused by what? It is caused by gram positive bacteria, right? Palatine tonsil is covered with which epithelium? That is obviously our what? Our stratified squamous non-keratinized. Stratified squamous non-keratinized. Palatine tonsil is seen in, now it is seen a palatine tonsil seen is, what is seen? It is covered by fibrous capsule, right? All of the following instruments are commonly used in tonsillectomy except, now talking about the instruments, right? Okay, now bipolar cautery, it is used. Harmonic scalpel, yes. Microdebrider is also used, but conduction wand is not used. Cryptomagna is remnant of second pharyngeal pouch, right? Second pharyngeal pouch. Tonsil developed from second pharyngeal pouch. Okay, anterior tonsillar pillar is formed by, it is formed by what? Tonsillar pillar anterior, that is formed by our what? That is palatoglossus fold, right? Palatoglossus fold. All of the following are true regarding tonsillectomy in children except, okay, extracapsular approach is best, that's right. Sleep apnea is an indication, that's right. Adenoid should also be removed along with tonsil if significantly enlarged, yes. Hemorrhage following tonsillectomy is usually arterial, no, it is not, right? That is paratonsillar vein, right? Okay, now moving to our next question. The patient presented with sore throat and fever, pain in the ear. The examination of throat shows following finding: he can be treated by following except. Now here, yes, the enlargement of tonsil is right here seen. So here penicillin can be given, second generation cephalosporin, macrolides, ciprofloxacin cannot be given, right? 25-year-old present with fever, sore throat and orinophagia. Fever, sore throat and orinophagia. He was diagnosed as acute tonsillitis and started an Mcqs lab. In spite of management of the condition worsened and examination of throat showed the following: he should be investigated for following except. Now here you can see the membrane over tonsil is seen here, right? Now diphtheria, yes. Infectious mononucleosis, yes. Okay, now here candidiasis is also the cause of membrane over tonsil, but this submucosal fibrosis is not, right? Okay, question number 45, right? 45. Now here what we have is not true about the marked structure given in the figure. What is marked structure? Obviously it is tonsil, right? Its capsule is formed by buccopharyngeal fascia. No, it is what? It is pharyngobasilar fascia, right? Okay, it is formed by pharyngobasilar fascia. Pain can be referred from here through glossopharyngeal nerve, that's right. White is removed. While it's removable, hemorrhage is usually venous, that's right. Peritonsillar vein, it is large, scrapped is cryptomagna. Its largest scrapped is cryptomagna, that's right. The remnant of what? Second pharyngeal pouch. Tonsillectomy is being done here in the given patient. This position is, we know, Roche position, that is also in tracheostomy. A 12-year-old unimmunized girl present with sore throat, fever and pain in throat. The throat examination reveals membrane over tonsil which bleeds on removal as shown in the picture. The most probable diagnosis is, okay, what is the most probable diagnosis? Obviously it is what? Our diphtheria, right? So this was all about what? This was all about questions from what? It was all about questions from tonsil. The point from which we are going to cover MCQ is from abscess of pharynx from ENT, right? Now without delay, let's begin with our question. So the first question that we have got here is, in which of the following location there is collection of pus in the quinsy? So the quinsy is also known as peritonsillar abscess, right? It is also known as peritonsillar abscess, and obviously there can be peritonsillar space. Now what is this peritonsillar space? It is the space which lies between capsule of tonsil, right? Capsule of tonsil and what? And superior constrictor muscle, right? Capsule of tonsil and superior constrictor muscle. Okay, the abscess between tonsillar area and superior constrictor muscle is known as, we have already said, right? That is quinsy or peritonsillar abscess, right? And one important thing about it here, it is that the most common organism is Streptococcus pneumoniae, right? Staphylococcus aureus, right? And here clinical feature is the patient will present with what? So sorry about it. So patient will present with what? The patient will present with pain in throat, odynophagia, hot potato voice, that is muffled and thick voice, right? Okay. Now let's move into another one. Quinsy is synonymous with, we have already said, that is what? That is peritonsillar abscess between what? Capsule and superior what? Constrictor muscle, right? True about quinsy. What is true about quinsy? Penicillin is used in treatment, that's right. Abscess is localized in capsule. No, between capsule and superior constrictor muscle. Commonly occurs bilaterally. No, that is also not right, right? It is usually unilateral in nature. Immediate tonsillectomy should be done. Okay, treatment is, no, immediate tonsillectomy is not done, right? Tonsillectomy is not done here. And patient present with odynophagia and drawing of saliva. Yes, I've talked about clinical features. That is what? Patient have what? Pain in throat, odynophagia, right? What? Even swallowing of saliva is what? Difficult. So drawing of saliva will be there. So E and E are the right answer. Moving further, all of the following are true about peritonsillar abscess except, right? Bulging in soft palates. Yes, it is seen, right? Soft palate involved, right? Swollen and congested are there, right? Okay, so it is the right answer. Now does not involve floor of mouth. Yes, okay, it does not involve the floor of mouth. Abscess collected lateral to superior constrictor. No, it is located what? Medial, right? Peritonsillar abscess medial to superior constrictor. So this is not the right statement, so this is the answer. And trismus is commonly associated. Yes, trismus is commonly associated. Now here trismus is due to what? Pterygoid muscle, which is in close proximity to superior constrictor muscle. So all statements are right except option number C. So C is the right answer. Treatment of peritonsillar abscesses. Now what is the treatment? Immediate tonsillectomy. Okay, now here, no, it is not the treatment. Incision and drainage. Yes, it is. Antibiotic alone, what? No, it is also not done, right? Antibiotic alone is not done. Treatment, what? The main stream of treatment is our incision and drainage, right? In which we do incision at the site of horizontal line through the base of uvula, right, to the line along anterior pillar, right? From anterior pillar there is what? Vertical line, and horizontal is line at the base of uvula. So at this junction, right, at this junction of what? Vertical line along the anterior pillar and horizontal line through the base of uvula. This is the point of what? Incision and drainage. So here we do it. So incision and drainage and along with antibiotic. I'm so sorry, here the option number D is the right answer. Incision drainage along with antibiotic is the what our treatment, right? Now here along with it we can provide analgesic also, right? Analgesic also, right? We can suggest our patient to have oral hygiene, right, by hydrogen peroxide and mouth washing, right? Okay. Now a 7-year-old child present with peritonsillar abscess with trismus, the best management is okay 7 year child is what 7-year child, right? So what we can do here in such case is that we can do immediate abscess drain orally, right? And peritonsillar abscess, immediate incision and drainage is done by intraoral incision, right? Okay. And the trismus here is never so much that the mouth cannot be opened for incision and drainage, so what we do intraorally only. The ideal time for tonsillectomy after attack of quinsy is, now what we can do here, now there is term called interval tonsillectomy, right? Tonsil are removed at around 4 to 6 weeks later following an attack of quinsy, so that is 4 to 6. Okay, here there are the two options 4 and 6 both, so what we go for what 6 week, right? This is known as interval tonsillectomy. It means after the attack after 6 week of attack we do what we do tonsillectomy. That's it. Infection of submandibular space is seen in, now where is the infection of submandibular space seen? It is seen in our what Ludwig's angina, right? Ludwig's angina is infection of submandibular space, floor of mouth, right? Okay, now talking about Vincent angina, it is what ulcerative gingivitis along with involvement of tonsil, right? Vincent angina is what differential diagnosis of membrane over tonsil. It is not Ludwig's angina, right? Ludwig's angina is related to infection of submandibular space, right? Okay, now moving further, what we have is next question, that is okay, true about Ludwig's angina is, what is true about Ludwig's angina? It involves both submandibular and sublingual space, that's right, spread through spaces, right? Okay, it involves what, both submandibular and sublingual space, right? Okay, now there are what, okay, talking about the submandibular space, right? Submandibular space lies in between what mucous membrane of floor of mouth and tongue on one side and superficial layer of deep cervical fascia extending between hyoid bone and mandible on the other side. Now this submandibular space is further divided into two spaces, right? Okay, myoid muscle separate these two structure, right? These two spaces, right? Myoid muscle separates these two structure. The above one, it is what, it is sublingual compartment, right? Sublingual compartment, and the below one, it is what, it is submaxillary, right? Submaxillary and also what, submental compartment below myohyoid muscle, right? It involves both submandible and sublingual space, right? It is the most common cause of what, our Ludwig's angina is what, it is what, dental cause, right? Dental infection, and it is what, it is bilateral, right? It is bilateral. And the important thing is that it does not spread through what, lymphatics. It simply spread through what, tissue spaces, not through lymphatics. So option answer number A, B and C are right. True about Ludwig's angina is rapidly spreading cellulitis of left-sided chest wall. Now it is not right. H. influenza is the most common cause. Edema of floor of mouth, sublingual and submaxillary space are involved. So obviously the right answer is what, edema of floor of mouth and sublingual and submaxillary space are involved, right? Ludwig's angina is characterized by all of the following except, right? It is characterized by all of the following except cellulitis of the floor of mouth, that's right? Now another is that caused by anaerobic organism. Yes, it is caused by what, it is caused by what, mixed aerobic and anaerobic organism, right? I'm talking about what, this alpha hemolytic streptococcus, staphylococcus are the main organism. Okay, now caused by anaerobic, that's right? Cellulitis of floor of mouth, that's right. Aphthous ulcer in the pharynx, there is aphthous ulcer in the pharynx, so it is what, it is not the right statement, right? And infection is spread to parapharyngeal spaces, that's right. So here all are true except aphthous ulcer in pharynx is not true statement. Which of the following is not true about acute retropharyngeal abscess? Not true about what, about what, acute retropharyngeal space. Now talking about retropharyngeal space, dysphagia, okay, retropharyngeal dysphagia, okay, dysphagia is what, is present, right? Dysphagia is present in retropharyngeal abscess. Swelling in posterior wall of pharynx, it is present. torticollis, it is present. Caries of cervical spine is usually common cause. It is not the right statement, right? It is not true about retropharyngeal space, right? Okay. Now moving to our next question, which of the following are true? Okay, now here, now we have got the questions from what? Retropharyngeal spaces, right? Retropharyngeal abscesses. Now before getting in detail, okay, retropharyngeal abscess, it is also what? It is also called space of Gillette, right? It is also called space of Gillette. Now here the node of Rovinier, right? Retropharyngeal node are present here, right? Okay, that is present here. Okay, now here okay, now all of the following are true about retropharyngeal abscess except confined to one side of midline. Okay, is it confined to one side of midline? No, right? It is true, it is confined. Okay, so it is confined to one side of midline, right? It is confined to one side of midline. Okay, talking about another one, right? Can be palpable orally by pressing finger on posterior pharyngeal wall. Can it be done? Yes, it can be done. It is confined to one space and palpation can be done. Lies behind the prevertebral fascia. Prevertebral fascia. Does it lie behind the prevertebral fascia? No, right? We know what we have got vertebra, right? Front of this vertebra we have got what? Prevertebral fascia. Now just front of them we have got what? We have got alar fascia. Now front of these we have got buccopharyngeal fascia, right? Now buccopharyngeal fascia. So here we are talking about retropharyngeal abscess, right? Now here space within this is what? This is prevertebral space. It is what? Danger space, right? And here it is what? It is retropharyngeal space. So this space lies between alar fascia and buccopharyngeal fascia, right? So it does not lie behind prevertebral fascia. So this is what? This is not the right statement. Confined to one side of midline, yes. Can be palpable orally by pressing finger on posterior pharyngeal wall. That's also right. Present with dysphagia and difficulty in breathing. That's also right, right? Retropharyngeal space presents with what? Striator torticollis bulge in posterior pharyngeal was usually seen on one side of midline, right? On one side of midline. Okay, commonest cause of chronic retropharyngeal abscess. What is the commonest cause, right? Okay, the commonest cause it is caries of what? Cervical spine, right? Caries of cervical spine. The true statement about chronic retropharyngeal abscess. What is the true statement, right? Okay, associated with tuberculosis of spine. Yes, it is, right? Cause psoas spasm. No. Suppuration of Rovinier lymph node, right? Yes, I have already said, right? Rovinier lymph node. It is what? It is the retropharyngeal lymph node, right? So the answer number A and C are right. And it is treated by surgery. No, it is not treated by surgery, right? Incision and drainage is done, right? Incision and drainage is done in adult by doing local anesthesia and baby by giving general anesthesia, right? A 30-year-old male underwent tooth extraction for dental caries. Now he presents with fever and trismus. Oropharyngeal examination is revealing that the tonsil are pushed medially. There is swelling in neck in upper border of sternocleidomastoid muscle. The mostly diagnosis is, now what is the mostly diagnosis, right? The mostly diagnosis is what? Our parapharyngeal abscess, right? Parapharyngeal abscess, right? Parapharyngeal abscess. It is also called pharyngomaxillary or lateral pharyngeal abscess, right? Okay, now here since what? Since there is a history of what? Tooth extraction, right? Tooth extraction, right? Tooth extraction, that is what? Mainly third molar tooth extracted, right? Extracted, tonsil is pushed medially, right? Medial bulging of pharynx is seen, right? So this is what, and mainly swelling is over middle one third or upper border of SCM, sternocleidomastoid. This is the peculiar finding of parapharyngeal abscess. Now moving into next question, we have got the middle-aged diabetic with tooth extraction. Same thing with ipsilateral swelling over upper one third of sternocleidomastoid and displacement of ipsilateral tonsil towards contralateral side, right? That is what? That is seen in parapharyngeal abscess, right? The medial bulging of pharynx is seen in, yes, medial bulging is seen in, that is what? That is seen in what? Parapharyngeal what? Abscess, or that's what? Pharyngomaxillary abscess also, or lateral pharyngeal abscess, right? Parapharyngeal abscess, all are true except midline swelling. Yes, it is. Abscess in pharyngomaxillary space. Yes. Trismus. Okay, now here. Okay, all are true. Okay, all are true except, right? midline swelling is not the appropriate answer, right? Midline swelling, abscess in pharyngomaxillary space, that's right. Trismus and torticollis, it is, right? Now here it is not the midline space, because obviously we have said it is what it is, present lateral to pharynx, right? That's why it is not midline space. True about peritonsillar abscess. Peritonsillar abscess, accept. Follows sore throat, hot potato voice, shifting of uvula to same side, orinophagia. There is shifting of uvula to what, opposite side. So this is not the right answer, right? There is, it follows sore throat, hot potato voice, orinophagia. These are all true about what, Quinsy abscess or peritonsillar abscess, or abscess present between what, our superior constrictor muscle and capsule. The most common cause of parapharyngeal abscesses, that is what, that is tonsillitis, right? Tonsillitis is the most common cause. Hot potato voice is characteristic feature of, right? Hot potato voice is characteristic feature of oropharyngeal mass. It is the feature of oropharyngeal mass. Trismus can be seen in all except Ludwig's angina. Is this trismus seen? Yes. Quinsy, yes, there is also seen. Prevertebral abscess, parapharyngeal abscess. In prevertebral abscess we don't see trismus, right? It is so behind, it is just front of what, vertebrae. There we can't see trismus. In Quinsy, the part of tonsil to be affected first is, now what is affected first? That is what, our crypta magna, right? Crypta magna, right, is affected first in Quinsy, right? The young boy came with a history of fever and severe throat pain and orinophagia, right? His voice is what? The boy came with history of fever, severe throat pain and orinophagia. The voice is what? The voice is muffled hot potato. This picture, which one of the following is most likely cause of his complaint? Now here what we can say here is, okay, as you can see right here, right, there is what, okay, now here this is because of what? This is because of what, our Quinsy, right? Quinsy, right? Quinsy, that is peritonsillar abscess, right? Peritonsillar abscess. Okay, now the given patient give history of toothache since 1 week. The diagnosis is, I've already said, thought to molar tooth extraction or tooth extraction. There will be always what? Okay, the tooth extraction. Okay, sorry, I'm so sorry, because here it is showing swelling over what? Swelling in this region. What is this? Submandibular region, right? So here it is not parapharyngeal abscess, because we need to go through diagram. That is what? That is Ludwig's angina. Here it is showing Ludwig's angina. Now next question, that is question number 28. The 35-year-old male present with dysphagia and difficulty in breathing. On examination there is bulge in posterior pharyngeal wall confined to right side of midline. His x-ray STN is given. True about above is, okay, as you can see, what is here? Now here there is what? There is fluid, as you can see, darkness is seen there. So here, though the x-ray cannot differentiate between option what, our abscess lie behind what, perivertebral fascia or suppuration of retropharyngeal lymph node. So these two options can be true. Here the x-ray cannot differentiate between option A and B. But since on examination there is bulge in posterior pharyngeal wall confined to right side of midline, therefore B, that means suppuration of retropharyngeal lymph node is the right answer. Suppuration of retropharyngeal lymph node. So okay, now moving to our next question, that is the given below is a picture of 30-year-old male, right? 30-year-old male who underwent tooth extraction for dental caries. Now he present with fever, difficulty in swelling and trismus. Oropharyngeal examination is revealing the tonsil are pushed medially, the most likely diagnosis. So here it goes in favor of what? In favor of parapharyngeal abscess, right? Tonsil is being pushed medially, right? Now there is what? There is orinophagia, trismus is there, right? Okay, now not true about the space through which arrow in the picture is passing. So here this space is passing between what? This space is passing through what? Now here this space is our, right, prevertebral space. No, sorry, this space is what? Retropharyngeal space, right? Retropharyngeal space. Why? Because here this one is what? This is our LR fascia, right? Now and here, sorry, this is our LR fascia, and here what is this? Okay, this is our LR fascia, and here what is this? This is our what? Buccopharyngeal fascia, and between these two we have got what? Retropharyngeal what? Abscess, right? Retropharyngeal abscess. So here it contains Rovenier lymph node, that's right. Abscess, acute abscess in this space are more common in children. It is right. Abscess present as unilateral paramedial balls of posterior pharyngeal wall. Yes, it is pre-vertebral space. No, it is what? Retropharyngeal space, right? Ludwig's angina arises from, it arises from where? Submandibular space. Yes, submandibular space, right? So these are all about the questions from what? These are all about the question from our what? The abscesses, right? Abscesses of pharynx. Abscesses of pharynx. Now we are going to cover MCQ from the topic of pharyngeal pouch, right? Now without delay, let's move into our what? Into our the first MCQ. Now here, which one of the following is known as gateway of tears? Now it is Killian's dehiscence. It is known as the gateway of tears. Now why it is called gateway of tears? Because here there is what? That is what? There is the weak point, right? Weak point from which, right? There is the what? Protrusion, right? Protrusion of what? Our Killian's or pharyngeal pouch, right? It is the most common site of pharyngeal pouch formation, right? That is Janker's diverticulum, right? Now here in Killian's dehiscence, right? What is going on is that there is thyropharyngeus muscle, right? Thyropharyngeus and cricopharyngeus. Now there is what? A gap between these two muscles, right? Because of which there will be weakness, and that's why there will be common site for pharyngeal pouch formation. One of the following is true regarding Janker's diverticulum. It is mostly asymptomatic, occurs in mid esophagus. Treatment is simple excision. It occurs in children. Now it's true, right? What is true about our Janker's diverticulum is that treatment is simple excision, right? Treatment is simple excision. It is usually present with dysphagia and symptom due to regurgitation of food into respiratory tract, right? So it is not asymptomatic, right? And Janker's diverticulum occurs from Killian's dehiscence, that is a part of hypopharynx above the cricopharyngeal cricopharyngeal sphincter. So this is option number B is also incorrect, right? Okay, and it occurs above 60 years of age, not in children. Dolman's operation is related to, now where is this Dolman's operation is related to Janker's diverticulum, right? It is related to our Janker's diverticulum. Now, an elderly male present with history of dysphagia, regurgitation, foul breath, hoarseness and cough, right-sided long crypts are noted on examination. The mostly likely diagnosis is, we have already said, that is Janker's diverticulum, right? In which there is what? Dysphagia, regurgitation, right? All of the following are true about Janker's diverticulum except, now it is acquired condition. Okay, Janker's diverticulum, it is what? It is, yes, acquired condition. It is false diverticulum, right? Now Janker's diverticulum is what? False diverticulum. Yes. Barium swallow lateral view is the investigation of choice. That's also right. Outpouching of anterior pharyngeal wall above cricopharyngeus muscle. No, it is what? It is outpouching of what? Posterior pharyngeal wall, not anterior pharyngeal wall. So this is what? This is the not correct statement. Janker's diverticulum is what? It is just what we said, hypopharyngeal diverticulum. It is hypopharyngeal diverticulum, right? Okay, moving to our next question. One of the following is true regarding Janker's diverticulum. It is Pulcian diverticulum. Okay, one of the following is true regarding Janker's diverticulum. It is what? It is Pulcian diverticulum. That's right, it is Pulcian diverticulum, right? Killian's dehiscence is seen in, it is seen in inferior what? Constrictor, right? Inferior constrictor. That's right, inferior constrictor. Now here the question is, an elderly male present with a history of dysphagia, halitosis, regurgitation, hoarseness and cough. His barium swallow is given below. The following is true about the condition except. So here most probably, as you can see, right? Now here, okay, which of the following statement is true about the condition except? So it is posterior pouch. Yes, that is true. It is false diverticulum. Yes, here it's talking simply about what? Janker's diverticulum only. It should be managed by excision. That's right. Due to traction from outside the esophagus. So it is not the right statement. So here all above three are the correct statement. This D is not the right statement. So this was all about question from what? This was all about question from pharyngeal pouch. Now the topic of discussion that we are going to cover is, we are going to talk about what? Oral cancer and miscellaneous conditions, right? Now without delay, the first question is, ranula is, what is ranula? Now it is what arise, what is ranula? It arises from the floor of mouth, right? Regarding ranula, all are true except, right? Now here It is extravasation cyst, yes. It is translucent, plunging may be a feature, yes, but it does not arise from submandibular gland, right? Ranula does not arise from submandibular gland. Ranula is, what is ranula? It is what? Extravasation of cyst, right? These are mucus retention cyst in sublingual gland. They are not pre-malignant, right? These are what? Extravasation of cyst. Ranula is what? What is ranula? It is the same thing, extravasation of cyst, right? True about aphthous ulcer. What is true about aphthous ulcer? These are recurrent also, and steroid is given as a treatment, right? Aphthous ulcer. Fluoridized spot in oral cavity arise from. Now, where does this arise from? It arises from sebaceous gland, right? Now, all statement about Plummer-Vinson syndrome are true except, right? So, common with iron deficiency anemia, that's right. Common in female, that's right. Pre-malignant, that's right. But here, commonly lead to carcinoma in lower 1/3 of esophagus, that's not right. Plummer-Vinson syndrome affects postcricoid area and upper part of esophagus, right? The upper part of esophagus, postcricoid area. Which of the following region is involved in Plummer-Vinson syndrome? That is postcricoid region, right? Postcricoid region is involved in Plummer-Vinson syndrome. Women with vitamin B12 deficiency presents with dysphagia and anemia, right? That is what is the syndrome mentioned in the presentation? That is Plummer-Vinson syndrome, right? It is triad of what? It is triad of postcricoid dysphagia, right? Esophageal web and iron deficiency anemia. These are what? These are the triad of Plummer-Vinson syndrome. Okay. Now, moving to next question. Question number 10. That is, in Plummer-Vinson syndrome, what is the percentage of postcricoid carcinoma? Now, here, what is the percent of postcricoid carcinoma? That is 10%, right? All are precancerous lesion of oral cavity except. All are precancerous lesion of oral cavity except. Diffuse aphthous ulcer is not pre-cancerous lesion, right? Other all leukoplakia, erythroplakia, diffuse oral submucosal fibrosis are what? Precancerous lesion. The most common pre-malignant condition of oral carcinoma. What is the most common? That is leukoplakia, right? Pre-malignant condition. Pre-malignant lesion in oral cavity include. What does it include? It include erythroplakia and what? Leukoplakia. Pre-malignant lesion are. What are the pre-malignant lesion? These are what? These are submucosal fibrosis, leukoplakia, erythroplakia, everything, right? Treatment of leukoplakia, right? What is the treatment of leukoplakia? It is local excision. The most common malignant tumor of adult male in India. What is that? That is our what? Cancer of oral cavity, right? Oral cavity. But here, oral cavity answer is what? Absent, right? Absent. The most common malignant tumor of adult male in India. So, what we go for? We go for lung cancer, right? Which carcinoma has best prognosis? Now, carcinoma of lip has the best prognosis. The commonest site of oral cancer among Indian population is site of oral cancer among Indian population. What is the most common site? It is what? It is alveobuccal complex. Alveobuccal complex. The carcinoma tongue, the most frequently developed from. Where does it develop from? It developed from what? Lateral border, right? It developed from lateral border. Carcinoma of buccal mucosa commonly drain into the following lymph node site. Carcinoma of buccal mucosa, it drain into what? Buccal mucosa, obviously submandibular, right? Buccal mucosa drain into ipsilateral submandibular level 1 as well as upper deep cervical level 2 and mid deep cervical level 3 and lower deep cervical level 4, right? Okay, moving to our next question. The carcinoma of lower lip secondaries are seen in carcinoma of lower lip secondaries are seen in. Now, where are these seen? These are seen in submandibular lymph node. Yes, the drain where? Buccal mucosa drain into what? Submandibular lymph node. Now, here this lower lip secondaries, right, are seen in what? Submandibular lymph node only. True about AJC staging of oral cavity carcinoma. AJC staging, right? Involvement of pterygoid plate is T4, right? Simply involvement of lateral pterygoid muscle in stage T4, right? In T4 there is involvement of pterygoid plate also, lateral pterygoid muscle also, right? Involvement of either pterygoid plate or pterygoid muscle, it is what? It is T4. The patient has carcinoma of tongue on right lateral border, anterior 2/3 with lymph node of size 4 cm in level 3 on left side of neck. Stage of diseases. What is the stage of disease? That is what? N2, right? N2. Now here the size is what? 4 cm, right? 4 cm. Tumor in cheek with 3 cm size with contralateral mobile lymph node comes under, now it comes under what? T2, N2 and M0. T2, N2 and M0, right? True statement about oral cancer is or are. What is true statement? Now, respond to radiotherapy? Yes. Surgery is a treatment of choice? Yes. Smoking predisposes? Yes. The most common site for squamous cell carcinoma in oral cavity. What is the most common site? Okay, that is our tongue. Tongue is the most common site of squamous cell carcinoma in oral cavity, right? The highest frequency of palpable metastasis in neck on presentation is highest frequency of palpable metastasis. Now where it is carcinoma tongue, right? Carcinoma tongue is the highest frequency of palpable metastasis. In N3 TMN staging of head and neck malignancy, right? What will happen there? There will be contralateral node of greater than 6 cm size. Contralateral node of greater than 6 cm size. Okay. Now moving further. A patient presented with 1 to 1.5 cm growth on lateral border of tongue. The treatment indicated would be. Now what would be the treatment indicated? Right? There will be what? Interstitial what? Brachytherapy, right? Interstitial brachytherapy. Now moving into next question. That is what? That is our edentulous, right? Edentulous. Patient has carcinoma of oral cavity infiltrating into lower alveolar margin. All of the following are possible treatment option except. So here segmental mandibulectomy can be done. Marginal mandibulectomy with removal of outer table. Radiotherapy cannot be given, right? So since radiation to mandible carries risks of osteoradionecrosis, carcinoma of lower alveolus, so it is not done, right? A 70-year-old male who had been chewing tobacco for past 50 years present with 6-month history of fungating soft papillary lesion in oral cavity. The lymph node are not palpable. 2 biopsies from lesions show benign appearing papillomas with hyperkeratosis and acanthosis. Most likely diagnosis is, now what is the most likely diagnosis? That is verrucous carcinoma, right? Verrucous carcinoma. The 50-year-old male came with ulceroproliferative growth measuring 3 cm in left buccal mucosa with 5 cm right submandibular lymph node and clinically no evidence of distant metastasis. What is the T and M staging, right? What is the T and M staging? That is T2, N2 and M0, right? T2 and 2 what? N2 what? C and M0, right? True about ND Gumpy deformity, right? True. What is true? Occurs due to defect of anterior mandibular arc and treatment is adequate reconstruction of anterior mandibular arc with bone and graft. Which one of the following 4 images is most likely to be pre-malignant? So here this is what? This is submucosal fibrosis. Here this is geographic tongue, right? It is what? It is candidiasis. It is what? It is Fordyce spot, right? Fordyce spot. So here, now here the option number what? Right? Now here what we have got here is, right, C is the right answer. That means A, submucosal fibrosis. A is what? Pre-malignant condition. Okay. Now moving into next question. SPB do not cause. What does SPB do not cause? Do not cause. It will not cause nasopharyngeal carcinoma. Okay, SPB do not cause, which is not right statement. That means nasopharyngeal carcinoma is by EPP is not the correct statement, right? Now 70-year-old man has smoking since 25 years. He presented with ulcer on vermilion border, such as upper border of upper lip. The most probable diagnosis is that he is what? Our basal cell carcinoma, right? A patient presented with mass in lateral border of anterior 2/3 of tongue, right? Lateral border and anterior 2/3 of the tongue. This will tend to metastasize to lymph node at which level? It will metastasize at what? First, second and third, right? First, second and third. So the answer is first, second and third. A 30-year-old gentleman with pan masala addict, right, presents with inability to open mouth fully along with restriction of tongue movement. Enumerate the oral cavity. Examination of oral cavity reveals the following. What is the most likely diagnosis? Now here, as you can see, right, now this is what? These are what? Our submucosal fibrosis, right? Submucosal fibrosis. So these are all about what? These are all about the questions from what? the questions from our what oral cancer and miscellaneous conditions. Oral cancer and miscellaneous conditions.